section. So please stay to the end of the webinar and click on the link provided in the comment section to attain your attendance and certificate later. Secondly, if you have any questions, kindly type your questions in the comment section and I will read your questions at the end of the lecture to be answered by our speakers. Lastly, kindly mute your speaker and switch off your video during the webinar session. Okay, without further delay, let me introduce our speaker for today, none other than my own colleague, Dr. S. Sovulama Bhavani. We both are serving Selangor for Ministry of Health. So currently, Dr. Bhavani is the head and specialist of Pediatric Dental Department of Hospital Kajang. She graduated from University of Malaya in 2000 and completed her master's from King's College, University of London, United Kingdom. She is also the members of Faculty of Dental Surgery from Royal College of Surgeons, England, United Kingdom. Her passions and interests definitely everyone is well aware of because of her lecture topic today, which is dental anomalies, particularly of MIH condition. That's why she's the best person to enlighten us about this topic. So without further ado, I pass the screen to Dr. Bhavani. So over to you, Dr. Bhavani.
Hi everyone, can you hear me? Okay, let me get my slides up. Okay, good afternoon to all the participants here. It's quite awkward to actually talk to the screen, so I'll try to do my best. Thank you to MEPD for inviting me to give this talk. Thanks Dr. Rosie for the kind introduction. Today our topic is going to be on molar incisor hypomineralization, and it's going to be on Learn, Unlearn and Relearn, the evolution that MIH took place over the last decade or so. So the first formal disclaimer, there will be a few materials and techniques and companies might mention in this talk. I have any official affiliation with any of them. That's in terms of formal disclosure. The informal disclosure is I'm not a lecturer to have a very detailed or very up-to-date slides, nor am I an expert in this field. Yeah, so I'll just share with you whatever knowledge that I have known and I have gathered over the years. Okay. So a little bit on quote by Alvin Toffler. Alvin Toffler is actually a futuristic in the 21st century, and he claimed that to evolve in life, you have to learn, unlearn, and relearn. And this ties very well with our developmental defect that we're going to discuss today, that is on MIH. Because when I was in an undergrad, to be very frank, I never knew the existence of MIH. It was only when I was sent to UK, I got the first exposure in a diagnostic clinic to pick up this condition. And when I was asked whether or not this condition is present in Malaysia, my answer to my consultant was no, because I was honestly I did not know that was actually MIH. So what they say that the mind doesn't know, the eyes don't see. So therefore, I did not pick up such conditions in Malaysia until when I came back to Malaysia, when I started seeing patients in my clinic, and I noticed that we do get quite a number of MIH cases. So therefore, perhaps this is something for all of us to be aware of. And more so now with our new LP8 card, MIH has been actually added into the diagnosis. So it's good for us to actually, first to pick up these conditions and know how to manage. Yeah. So this is basically some clinical photos of MIH that we actually come across. As you can see that you can have a badly broken down 6 with yellow-brown lesion. You can have white spot lesion with atypical restoration involving the distal part of the 6s where there's no contact point. Or you can have a breakdown in a very abnormal position, like incisor edge of the incisor edge of the upper front tooth. Okay. So the outline of this talk is going to be based on the titles that stated above. Okay, how did this MIH start about? Back in 1970s, a group of dentists in the Public Health Service Department in Sweden actually noticed an unusual defect, which was quite extensive, and it involves the enamel. This was increasing in number among the school children, and they were not sure what was the etiology of this condition. However, they noticed that this condition was more confined to the first permanent molar and the permanent incisors. The problems they encountered when they faced this condition were this tooth was very difficult to clean, there were extreme sensitivity of this condition, and whatever restoration they placed at that point of time were did not last very long. And just to bear in mind, at that point of time, amalgam was the state of art. So what was it then? Okay, when they actually look into various literatures, this condition was actually reported and documented in terms of the clinical findings or the problems they encounter, but they all carried various names. So they were names such as cheesy molar, opaque spots, idiopathic enamel, non-endemic molting enamel, internal enamel hyperplasia, and also non-fluoride enamel opacity. Not until 2001, when Wehenjan actually coined down all these things and came up with a very comprehensive descriptive way of describing this condition. What she actually said that this is actually a hypomineralized of a systemic origin, meaning to say it actually describes the whole lot. It's basically a less mineral content of a systemic origin. That means it's not a localized condition, and is caused by the demarcated qualitative defects on the enamel involving 1 of 4 first permanent molars frequently associated with affected incisors. This was about 20 years ago. Okay, this definition has gone through a lot of debate over the last few years because there has been a lot of new discoveries in terms of whether or not this definition actually presents the actual condition. This is because lately they have found that such hypomineralization actually occurs in the second primary molar. You can also find them in the cusp tips of the permanent molar, on the permanent premolar, on the premolars and the second permanent molars as well. Then again, in 2012, Balmer, when he actually conducted an epidemiological study in UK, he realized that MIH, as in the definition says, you have to have hypomineralization of the molar. Only the incisor is an optional, whether or not the incisor occurs or not. However, in Balmer's study, he said that there are situations whereby there may not be a molar involvement, there can be only an isolated incisor involvement. So he actually proposed the terminology incisor hypomineralization, molar hypomineralization. However, this thing is still in debate, and what is acceptable still worldwide is still the terminology MIH. However, a lot of people are still looking into this terminology, and whether or not it will be revised in future dates, we are not too sure. There's also another group of school of thoughts that think that actually, after all, MIH might be just a spectrum of amelogenesis imperfecta. All right, this is just a different school of thought. We shall keep you updated if there's any changes in future. So what actually happens? Okay, this is basically an enamel defect. As we know, enamel is the hardest and the most mineralized tissue in the human body. It is said it's hard, so much more harder than the bone. 87% of the enamel volume and 95% of its weight is actually composed of very tightly packed organized crystal. Meaning to say that this is the reason why when there's a light shine on the enamel, it gives you that blink, you know. Yeah, so what happens in the MIH case, the affected enamel has very less mineral. It is said in studies that the mineral compound can be less up to 20%. But in certain cases where the severe MIH, the mineral compound can be less up to 60%, right? And the protein component can be high, so much more higher, to up to 3 to 15 folds. What does all these things sum up to? It all basically brings up for us to know that this can cause poor etching and poor bonding strength whenever you have to restore a tooth which has MIH condition. So then they looked into all the histopathological analysis of this condition. They looked into light microscopy, polarized light microscopy, scanning electron microscopy, you name it, they did it, right? Okay. And what they actually found was there's increased porosity in the enamel of this teeth. And the white creamy lesion apparently is not as porous compared to the yellow-brown lesion. What does all this porosity actually means? It actually means that the tooth is so hollow that it is so permeable to dental bacteria. So your Streptococcus mutans can actually hold in hands and dance down the tubules and, affect the tooth caries easily. Okay. What causes all these things? You see, when we know a condition, we know that it's causing clinical problem, we always want to know what causes this, because we want to nail it, right? What causes it? So there's been lots and lots of systematic reviews done at a periodic period to look into all the studies that has been carried out to be able to find out what causes this marked clinical problem. Okay. So this was done in 2010, yeah? Okay, but was only published in 2012, okay? They claim there is no possible specific cause that they could actually relate to MIH. However, there's some association which they can actually make. For example, conditions like high fever, hypoxia, hypokalemia, or exposure to certain antibiotics as amoxicillin, macrolides, or dioxins, okay? Then again, back in 5 years later, they actually did another systematic review to look into if there's any other cause during maternal condition that could have been related to MIH. Then they found out that conditions such as early childhood illness, such as fever, asthma, pneumonia, is very closely related to the development of MIH. Then again, 5 years down the road, again, they did another systematic review. Okay. And they found the conditions like maternal illness, psychological stress. You tell me who is not psychological stress when you're pregnant? Okay, cesarean delivery complication, respiratory disease, fever. Which child doesn't develop fever in the first few years of life? Yeah, so they all associate these things to the development of MIH. Bear in mind when we actually interpret all these studies, okay, when they actually look back how they actually come up to determine the etiology factor or the causative agent, it is basically based on recall basis. Meaning to say, let's say if you diagnose a child in a clinic and you think it's an MIH, you ask them a retrospective question: what was the insult that took place at the time of delivery, or the time of early age of life, or during the time of last trimester? Yeah, so it's all based on recall based. So it's quite difficult to actually pinpoint to say that this particular agent could have caused that condition. Okay, so as anything else in our dentistry, just like caries, it's a multifactorial etiology. Okay, there's maternal cause, there's neonatal cause. Okay, so basically to sum it up, any insult during pregnancy or the first 3 years of life puts the child at risk of developing MIH. Okay, this is something new. This is hot from the pot. This is actually published in March 2020. This is by a group of researchers from China. They actually coined down that there's a particular gene which is closely related to MIH. And then in October 2020, another group of experts in Europe actually claimed there's another group of genes. I mean, this genetic study is the state of art now. So yeah, it's for us to know. Yeah, I shall keep you all updated if there's any other new discoveries with regards to this. Okay. So now we know what it is. Let's see how common this condition is. Okay. After the terminology of MIH, there has been a lot of global awareness about this condition, and there has been worldwide variance of the prevalence study. The results that have been reported in the literature varies from 2008 to 40%. So whenever a study has got a wide variance, you actually query whether or not this is actually true. So when they actually did look into it, they realized that there's some lack of standardization tool to report the MIH condition. And whenever the results are quite low, as in 2%, could there be an underestimated statement? And the reason for this is coined down to lack of uniformity. Okay, they say that probably the sample size, the tooth involvement, and the lesions are not uniform. What they mean by not uniformity in sample size? When we look into the published data, some sample size that were actually taken into the epidemiological study are from the age group to 7 to 9. In some studies, it's 7 to 12. Some samples are from patients referred to the specialist center, whereas some are actually in a field-based study, on a population-based study. Okay, in tooth involvement, some studies consider as in presence of one permanent molar, it's fine to actually be included in the study. In some papers, they actually look out for all the index teeth to be completely erupted. For example, all the first permanent molar, all the upper incisors and the lower incisors. So as in lesion size, this again, there's variety in the published data because majority of them says you include lesions more than 2 mm in diameter. But in some studies, they in fact include any lesions up to 1 mm in diameter. So due to lack of uniformity, there has been disparity in the actual data. So they did a systematic review again to look into the studies of MIH, and they actually concluded there is a lack of standardization. And they published a paper saying there is actually a need to have a standardization whenever anyone wants to conduct any form of study with regards to MIH. Following that, an epidemiological study training manual has been published. This was published in 2017, and this module comes into 5 modules, and there's also a 5th module whereby it comprises the exercise forum. For those interested, you can actually look into this paper. Okay. So what's the worldwide prevalence of MIH? There's a very interesting website called the D3 group. D3 it stands for Dental Developmental Defect. Okay. They have got over 100 pages that says about MIH. So when you actually look into one of the pages, they have actually the whole globe marked in green, the areas that have conducted prevalence studies. So all you have to do is just click at the area and you will know what the prevalence is. So on that, the worldwide prevalence is summarized in the in the primary molars. This is because they actually considered the second primary molars as well. This is about for 9%, whereas in the studies involving the first permanent molar is up to 15%. So what does that mean? This means 1 in 6 children worldwide is diagnosed of MIH. So if it's 1 in 6 children, is that bad? Well, that's for us to think about. But however, affected molars may face 10 times higher risk of developing dental caries compared to a tooth that is sound. And this is more so if it's a severely hypomineralized molar. Now, that is really alarming. So when we look at the prevalence study in Malaysia, this was published by Hussein in 2015, and she claims that the prevalence in Malaysia is about 17%. So this is the paper for those interested. So let's compare this to caries. What's the prevalence of caries in our Malaysia? This is something that I picked up on the net. The oral health status of 12-year-old school-going children, Malaysia. This is from the National Health and Mobility Survey, 2017. The caries in school children is 3 out of 10. So that's about half of these kids actually develop MIH. So how do you go about diagnosing this lesion? So the ideal time to diagnose MIH is when the tooth, as soon as the tooth erupts. This is because you do not want the tooth to have any superimposed by caries or breakdown, which might complicate your diagnosis. You have to examine both the primary and the permanent dentition, and examination is purely visual on a clean, wet tooth. You don't have to dry the tooth or blow air or whatever not. Yeah. So what are the things to look out for? You look out for lesions such as demarcated opacity, that means very confined white lesion, and do examine areas such as the occlusal and also the buccal or the lingual. Okay, look out for lesions like atypical caries. What do you mean by atypical caries? Caries usually occur in pit and fissure or the areas which in contact, as in the proximal surface. But if you notice a caries on a smooth surface, like in buccal or areas of the distal of the sixes, that should ring a bell. Why is that caries happening in a very atypical area? And also look out for areas for post-eruptive breakdown. What do you mean by post-eruptive breakdown? As soon as the tooth erupts, it tends to develop caries. The child would have had good oral hygiene, excellent oral hygiene. All the primary teeth would be sound or very mildly carious. But as soon as the sixth erupts, it tends to break down. And the other condition that you can actually look out for is the sensitivity. Very rarely pediatric patients actually complain of sensitivity. But if a child is avoiding to take certain food and complains that they can't rinse their mouth or they can't eat ice cream, that should ring a bell. There's something going terribly wrong. So the clinical presentation of MIH is a spectrum. Yeah, it depends on the severity. It can vary from white spot lesion to yellow brown lesion. Okay. So what are the classifications of MIH that we know of? This again, once MIH has been coined down, and there has been few classifications to actually divide this condition. Yeah. So 2 years after Wayne Jime came up with the terminology, the EAPD group gathered with the experts in the pediatric dentistry to look into how to actually classify this. So I'm just going to go through with you a few classifications there has been over the years. Then I will suggest to you something which is more clinically practical for us to use. Okay. So in conditions such as absence or presence of demarcated opacity, post-eruptive breakdown, is there an atypical restoration? Has there been any extraction of the molars? Has there been failure of eruption? Okay, these are the basic classifications which they introduced in 2003. Then in 2006, they actually revised the whole lot and they said, look, that is not so comprehensive. Why don't we come up with something a little bit different? Look at for lesion for hypoplasia, opacity, post-eruptive breakdown. This was 3 years after. Then they realized that did not actually say how bad the tooth is broken down. So they came up with another classification by Ghanem, and this classification actually looks into the extent of the lesion. If you look at it, it actually says if 1/3 of the tooth is involved, or 1/3 to 2/3 of the tooth is involved, or the 2/3 of the tooth is involved. It actually tells the extent of the lesion. Of course, if you look at it, it's quite a lot of numbers, a lot of things to look into. Okay. Then in 2017, this is quite the latest classification. They actually look into the complaint of the patient in terms of the sensitivity, and they look into whether or not there has been any enamel breakdown. They incorporated the extent of the lesion, and they tied down all this thing to the treatment need. This is well and good if you're really going to do a very detailed study, but trust me, it's very complicated to actually put it in practice, at least for me. So what I feel that this is what I do in my clinic as well. Whenever we see cases of MIH, we actually diagnose to mild, moderate, or severe. Okay. The reason why we actually classify these conditions in this way, it's for me to actually know which cases to do what treatment. Yeah. Okay. So if it's a mild cases, what does it mean? It means demarcated opacity. You can hardly see, usually it's not even complaints, just an incidental finding, confined to areas of non-stress bearing, such as the buccal surface or the lingual surface. There's no caries, there's no hypersensitivity. The incisor involvement is very mild if present, such as this. But having said that, in kids nowadays, even the mild incisor hypomyelinization can be quite a severe complaint to them, can be a severe aesthetic concern to them. Yeah. So what does moderate MIH means. Moderate MIH simply means there's demarcated opacity in the molars and incisors. The post-eruptive breakdown is present. Okay, there is very little caries. It can be superimposed by caries. There's normal dental sensitivity. Okay, as in here. Right. So what is severe MIH? Severe MIH is post-eruptic breakdown, there's crown destruction, there's caries, there's sensitivity, there's obvious aesthetic concern, such as this. Yeah. So to be very honest with you, it is very easy to classify mild and severe. So whichever that doesn't fit mild or severe, just put in a moderate. Yeah, that's easy. So let me tell you something important here. Okay. As I said earlier, hypomineralization doesn't only confine to the first permanent molar and the incisor. This is something that that is being debated now. Okay, why they say this is because they find a lot of hypomineralization actually in the second primary molars. For all you know, all the teeth that actually we are taking down in our CDT under GA and all these things could, for all you know, could all be an hypomineralized ease. Yeah. So it can actually occur as a breakdown on the buccal or the palatal surface. And when they did the study, they realized that they concluded that 50% of hypomineralized first permanent molars are actually associated with hypomineralized second primary molars. That's quite alarming. So what does this mean? This means that if you find a child with hypomineralized second primary molar, this can actually be a predictor for the MIH. Therefore, it indicates us to have a close monitoring of the developing sexes. Yeah. And there's another interesting thing which I want to say here is they claim that if there's a hypomineralized molar, there is chances of having 25% of these patients may have developed hypomineralization on the permanent canines as well. As I said much earlier, these things are still new, still in debate, are still being investigated. So yeah, always look out for hypomineralization on other teeth too. Okay, let's look at the differential diagnosis of MIH. Okay, MIH is usually once you know what it is, it's quite easy to pick up. Yeah, let's put it that way. If you know what it is, it's quite easy to pick up. But then again, it can be clouded by a lot of other conditions as well. For example, fluorosis. But have in mind, fluorosis. What is fluorosis? Fluorosis is basically something systemic. It's diffuse. Yeah, it has wide opacity all over the teeth. It's symmetrical. It's caries resistant. Okay, that is fluorosis. What is the other thing that you could actually get confused with AI? As I said, there are some school of thoughts that's actually wondering whether or not MIH is a spectrum of AI. You know, as you know, AI is a spectrum of condition. Could this be just a spectrum? So yeah, that's still in debate. So, but the thing about AI that it's very marked as a very strong familial history, which they can't find anything conclusive with regards to MIH yet in terms of familial history. But then again, with these genetic studies and all, we might come up with such data in future. Okay, and AI usually involves all teeth, both the primary and the permanent dentition. And of course, as you know, there is a variety of cases of AI as well. Okay, the other thing that we can actually easily get confused is the localized enamel hypoplasia. This is more so, especially when especially so in the cases like localized enamel hypoplasia with enamel incisor hypomineralization that I told you that was published in Balmer's paper. Yeah, but usually this kind of conditions you can associate with some chronic infection in the primary dentition or some trauma in the primary dentition, for example a severe intrusion or whatever not, and this is usually asymmetrical involving one tooth, and yeah, it's quite straightforward. Yeah, so what are the management of MIH? Okay. Management of MIH has to be taken into consideration of holistic approach. You have to take into the patient care, the parent care, the clinicians' skills and knowledge. What does how much can the patient cope with whatever treatment you want to provide? What are the expectations of the parents? You know, what are the concerns? What are the complaints? A lot of things. There are a lot of things that you actually have to consider. As I used to tell my officers, you know, when you're actually seeing a patient, you have to get, you know, you have to get all your five senses activated. You know, you have to like be all well and aware. And you know, if you have your sixth sense, you know, use your sixth sense and see what they actually foresee or predict out of you. You know. So yeah, as you know, first look out for the clinical problems. Okay, is there any sensitivity? Is the child avoiding to brush the area? Okay, the child may not say the tooth is sensitive because the child may not able to describe the complaint, but the certain habits such as refusing to eat ice cream or refusing to brush teeth, you know, which actually leads to a plaque stagnation on that particular area, severe very early pulp involvement, okay, such as, and then the child develops very high risk to caries, you know. This kind of children usually presents with behavior management problem. They are very fretful, they are very agitated. Then the management of the tooth itself, it's very difficult to anesthetize this teeth. Your local doesn't really it's not very effective. Sometimes you might have to use intraligamental injections. You might have to put rubber dam even if you want to restore this tooth, because you don't want to expose the other areas of the other sixes which are hypomineralized, which can actually make things worse for the patient. Patient might feel very sensitive. Okay. In some conditions, you might have to use different LA such as articaine. Okay. Especially if the incisors are involved, aesthetic is a concern, and this can have psychosocial impact to the child. The child can have history of bullying in school. The child can feel very low self-esteem. Yeah. So what is our approach? Our approach should be very clinical based, as in everything in how what you do or practice. It should be very clinical based. Tackle the complaint. What's the complaint of the patient? Is it sensitivity? Is it dental caries? Assess the child, assess the parents. Okay, what are their expectations? How much can they cope? Assess the tooth. How much can you do? Is the tooth worth to restore? What can you do for immediate restoration? What can you do for intermediate restoration? What is the long-term plan for the patient? Okay, have all these things actually, you know, all these things should be just working in you as you actually see and club this patient. Yeah. And most of the time we do further investigations such as doing the OPG, and when you take a OPG, you look out for things as presence of the third permanent molar. Is there any other dental anomalies such as hypodontia? Is there any developmental defects as in the occlusion defects? You know, is the patient class 2, class 3? Okay, all these things should actually be looked into. Yeah. So as in management of MIH, there has been various guidelines around the world. This you can actually find in the Dental D3 Group website as well. Okay. However, all these guidelines are claimed to have very low quality of evidence. Okay. I'm going to propose to you a few management technique, but there might be some, disparity among the specialists or the clinicians. Don't be surprised. I'm not surprised by that, because even the studies done in UK, there has been a significant difference and confusing and uncertainty among the general dental practitioners and the specialists in the UK, despite having a guideline to follow. Yeah. So, however, there's a recent systematic review that was done, and they claim that, that there are a few things that a lot of people agree upon, such as in terms of sensitivity, do the remineralization, do the sealant. In terms of restoration, do the composite. And then you do your preformed metal crown, your silicate crown, and extraction should be the last resort. You should consider a lot of factors. So let me go into the detail. Okay. So management of MIH. Basically, as I said to you, divide to mild, moderate, severe. If it's mild, preventive. Moderate, obviously. Preventive has to be there all the time. Preventive and restore. If it's severe, preventive, restore. In case of molar, may have to consider extraction. Okay. So I'm going to divide this treatment plan into management of molars and incisors separately. There might be a bit of overlap in the materials, but I will try to emphasize the need of each condition as we go on. Okay. What's the preventive care? Everything, your OHI and your diet advice. That has to go on. Okay. But there are certain things that you might want to emphasize in terms of MIH. You have to do a proper brushing. Make sure you brush until the back teeth can be reached. Yeah. Use a fluoridated toothpaste. It should be an adult toothpaste. Okay. A pea size. The amount of fluoride in an adult toothpaste is 1,500 parts per million. The amount of fluoride in a kid's toothpaste is only 400 parts per million. So your adult toothpaste is 3 times stronger than a child toothpaste. Yeah, in some places, fluoride mouthwash is being used. I mean, Colgate. I mean, I have no affiliation to Colgate, but Colgate has come up with some good fluoride mouthwash. But having said that, you might want to use it under supervision. The child has to be monitored and ensure the child can actually spit out whatever mouthwash that the child has used. You can use topical fluoride, as in fluoride varnish. As in your Durafat. Durafat has very high concentration of fluoride. The concentration of fluoride in Durafat is 22,000 part per million. So it's really like 22 times stronger than your toothpaste. Topical fluoride such as Durafat is actually for in-office use. Yeah, so when you have the patient on your recall system, 3 monthly or 4 monthly, you might want to put on your Durafat. You can actually give the patient tooth mousse. Tooth mousse is a casein-based, a milk-based product which actually contains calcium and fluoride. Okay, tooth mousse is actually advised to be used the last thing at night. It's not a substitute for toothbrushing, to be used last thing at night before the patient actually goes to sleep. Icon and SDF. I'll talk about these two things later. And of course, do your fissure sealant as soon as the tooth erupts. Okay. Of course, how to do a fissure sealant as soon as the tooth erupts? Isolation might be a problem. Yes, I do understand. Resin-based sealant is the best sealant. Ideally, you etch and then you put a bit of bonding to actually improve the retention of the sealant. Then you put your sealant. But however, when the tooth has newly erupt, you might just want to place some GIC due to difficult isolation. You can use your Fuji 9. Sorry, not a Fuji 9, your Fuji 7, yeah, to place your fissure sealant on the sixes. Yeah. So let's talk about Icon. Icon is something new. Okay, y'all are okay with the fluoride, right? Okay, I forgot to mention that. Why do you want so much of fluoride? Okay, as you know, this tooth is actually not so strong, means it's not hard enough. So you want to change all this hydroxy apatite to fluoroapatite. Fluoroapatite is so much more stronger to any attack. So that's the reason why you have to load this tooth to fluoride. Okay, so that's with regards to all the fluoride. So let's see how resin infiltration by the use of Icon. Icon is actually the name of the brand. The actual material is the resin that actually infiltrates. Okay, this thing has got no bioactive property. However, it is claimed to improve the enamel hardness by 15%. Okay, why does the increase in the enamel hardness helps? Because it helps to protect the acid attack, protects the breakdown, and they also claim that Icon helps in the bonding of the restoration material, especially resin-based restorative material. So basically what this Icon resin does, is actually it just infiltrates into all this micro leakage and just fills up this area and makes the tooth harder. Okay, it is more potent used in areas of incipient caries or white spot lesion. Okay, this was actually discussed in last week's talk on silver diamine fluoride. Okay, I mean, when I read about it or when I listen about it, I think this is actually a magic potion. Yeah. Okay, this was actually in existence since 1940s. It has been used lots and lots of cases in Japan. However, lately, after FDA has recognized this to be used as a dental product, it has sort of got its new birth. Yeah. So SDF actually contains 38% concentration of fluoride. And what does this mean? It means the concentration of fluoride is 44,800 parts per million. That means it's double the concentration of your Durafat. Okay, the chemical composition of fluoride, I'll just go through this briefly because it was actually discussed last week. Yeah, so the chemical composition of fluoride is the silver component, which is the antimicrobial, the ammonia, which is the solvent, and the fluoride, which acts as the remineralization. So you have the best of everything. Okay, it's actually very good because it helps in cases of sensitivity by occluding the dentinal tubules. However, the drawback with SDF, it causes stain. I have not used SDF myself because I've not been able to purchase it this year, but I plan to purchase next year and try to put in practice. But if you are not careful, you might end up giving the patient some tattoo along the area. So you might want to isolate the tooth and the mucosa and the skin lesions before you actually apply SDF. But studies have claimed that SDF helps in control of sensitivity within 24 hours. So yeah, it's actually a good product. It also helps to arrest the caries. So what are the restorative options for MIH molars? Just like any restorative materials, for the molars, you can use your composite, you can use your GIC as a, well, I wouldn't say GIC as a permanent restoration, yeah, or resin modified GIC, not as a permanent restoration. You can use a stainless steel crown. Stainless steel crown is okay, but of course it's not going to be there forever until the life of the patient, yeah. You might want to convert it to an indirect adhesive material or direct like crowns or porcelains or whatever not, okay. So whatever choice of material to use, again, then you have to have your mental calculation and prediction and thinking and planning, what is best for the patient, what is best for the tooth, and what is best for you as a clinician, given the environment and the situation and whatever not, yeah. So as we know, I just put up this chart, this table, as in all the advantages and disadvantages. I mean, we studied this in our second year dental school. So just to recap, GIC has got its advantage. What's the advantage of GIC? It's just easy to place. Yeah, it's fluoride bleaching. Okay, so it helps. It actually does do some help. However, it doesn't last very long. It's very brittle and it wears off quite easily. In the other end, resin-based composite is actually aesthetically more pleasing. It's a little bit technique sensitive, as in you need to have a good moisture control, and this can be quite tricky in children. Yeah, so let's look at the materials. Okay. So to get the best out of composite and GIC, you can actually do a sandwich technique. Basically, what this means is, on the first visit, you just clean up the tooth surface. If it's very deep, put some dical, dump in some GIC, get the patient feel very comfortable. It is actually claimed to be a sedative interim restorative material. However, you have to get the patient in again to actually remove whatever GIC that you have done, up to a few of like 2-3 mm, and then put in your GIC as your composite as a restorative material above it. Okay. So the thing about putting in restorative material as composite as a restorative material is the issue of bonding in MIH tooth. So researchers has proposed to use a technique called protein removal technique. This is done by applying 5% of sodium hypochlorite in a rubbing motion for about 60 seconds on the tooth surface. Yeah. So do you use amalgam in MIH molar? Well, amalgam is actually a no-no. Why is that so? Because the atypical cavity shape of the MIH tooth, amalgam requires mechanical preparation, more extensive mechanical preparation. It's not adhesive and it's actually poor isolator. So it's not really a material of choice. Stainless steel crown, this is our favorite, right? Okay, stainless steel crown, as you know, in a set of stainless steel crown, you can actually obtain the crown for the first permanent molars as well. It has the morphology and the contour of the crown. It covers the all the tooth surface, the top, the bottom, the right, the left. Yeah. However, it's not so aesthetically pleasing. There are a few type of crowns that is not of this color, such as Pro-Tem. It's a resin-based composite, resin-based crown. However, it's a bit technique sensitive to actually use that. Okay, so this can be used. As a child gets a little bit bigger, you can actually opt to do more lead-based restorative material, restorative things such as cast onlay or indirect composites or ceramic. These are not really advisable in children because, as we know, the crown length is quite short, there's large pulp, and the treatment time is quite prolonged, and you actually require child's cooperation. So in older children, when they're 16 years and above, which is actually not more your problem, but you might want to know, okay, because you might want to refer to your restorative colleague, yeah. So to say that, you know, you have done so and so and so, however, you think the child will require so and so, so you're referring to you, so the child might need a full or partial crown, you know. This involves aggressive tooth preparation when the child is actually at the a full stable occlusion, okay. As we know, these things can be a little bit more expensive, tricky to do, and may involve more than one visit. Okay, this is something new I want to share with you. This is again hot from the pot. This is like in 2020 published in 2020. Yeah, they claim doing an overlay veneer, composite overlay veneer restoration using CADCAM. Okay, of course, CADCAM is quite an expensive gadget to actually have, but this study claimed that it's actually well tolerated among children. It doesn't require taking impression, it's easy to perform, and it's faster for the dentist and the child. So what they basically did was, this is an 8-year-old child. They actually removed the old amalgam restoration. As you can see, amalgam doesn't stay. You can't. It's literally impossible to actually place an amalgam in a restoration as such. Yeah, in a caries as such. Yeah, so you remove all the amalgam and have a clean cavity. Then you have your probe, CAD-CAM probe, and then you have it casted and you cement it with your under amalgam. Okay, let's talk about SDF. How do you use SDF? SDF seems to tie very well with the latest approach to dentistry. As you know, in this COVID era, we are going towards a non-AGP, minimally invasive treatment approach, or minimally intervention dentistry. So how does this actually tie down to our practice now? Okay, there's a new technique that's been introduced called SMART technique. It actually means silver modified atraumatic restorative treatment technique. What it actually means is applying some SDF on the tooth surface, recalling the patient after a week or two, and then placing some GIC. Yeah. So what they actually say that high viscosity GIC is opaque and it actually helps to mask the SDF state. And as you know, SDF would have arrested the caries, improved the sensitivity, and whatever that's necessary for the tooth. So extraction of the molars. This is actually what we actually push for when we actually see a very severely involved MIH molars. There are a few indications when you actually put the tooth or you push the tooth for extraction. When the prognosis is very poor, when it's actually severely sensitive, when there's endodontic or uncontrolled periodontic problem, lack of patients cooperative, or parents are not really committed to treatment. Okay, there's orthodontic indications whereby the second premolar is sound, but then the first permanent molar is so badly broken down. So it's not really fair to actually sacrifice the premolar when you can actually get away with the molars, yeah, to create the space. Okay, so however, before you do any extraction, you have to do a full dental assessment. Yeah, do your clinical and your radiographic evaluation, do the occlusal analysis, check on the presence, the position of all the teeth. Yeah, and always take a photographic record as well. These patients might have to be discussed in a combined specialist clinic with the orthodontist, and because this patient may require orthodontic input to actually close the space. Why is this extraction need to be done in a planned timing? It's because we want the second permanent molar to drift into the space of the first permanent molar. The reason why this is because if you actually happen to leave some residual space, orthodontic treatment may be necessary. So the best timing for extraction of the first permanent molar is around 8 to 11. Okay, the Royal College guideline 2014 says at the time of formation of the crown and the flotation of the second permanent molar. This you can see when you actually take a OPG. However, clinically, you can actually predict at the time of eruption of the laterals, okay, upper laterals. However, despite all this, following all these rules and regulations strictly, studies have reported that the ideal positioning only takes place in 94% in the uppers and 66% on the lower arch. Okay, this is another paper that has been published by Paul lately in 2017. This looks into the presence of third permanent molar. If they say that if the tooth is of low prognosis and the third permanent molar is there, then you might want to just go ahead to extract the first permanent molar. Okay, so the ideal time for extraction, as you see in the OPG, when the bifurcation formation of the second permanent molar and the formation of the third permanent molar. Okay, extraction pattern, do we have to balance and compensate? Okay, whatever you want to do, especially the extraction of the permanent tooth, you must discuss with the parents and the patient. Okay, so the rule of thumb is need not balance, no need to balance, no need to do the right and the left side. If you take out the right side, you don't have to do the left side or vice versa. However, when you extract the upper first permanent molar, you don't have to extract the lower first permanent molar because there is very unlikely for the tooth to actually over-erupt. Okay. However, if you're extracting the lower first molar, the over-eruption of first permanent molar is more likely. Okay. So what happens if you do a premature or delay extraction? If you do a premature extraction, there's a very high possibility of distal drifting of the 5. And when this happens, there's labial segment retrocline and there's a possibility of deep bite formation. Okay. When you extract the first permanent molar late, that means beyond the age of 11, 12, there's a possibility of mesial tipping of the 7, there's distal tipping of the 5, and that can lead to residual space. Okay. Treatment option for the MIH incisor. Again, whatever treatment plan that you're doing, you have to consider a lot of things, as in the severity of the condition, the aesthetic concern, and also always be very cautious because the tooth can have a very immature and the tooth is immature and can have very large and sensitive pulps. Okay. MIH incisor, as we know, it can be random, it can be 1, it can be 2 molars involved, it can be white, chalky appearance, it can be yellow-brown, it can be breakdown, all these things can actually cause psychosocial concerns for the patient. There are a few materials here. Okay, the ones in blue are least invasive. The ones in red are more invasive. Okay, whatever approach that you take, try to go for the least invasive ones. You might have to do this management, this technique on its own, or you might have to do it in combination. Okay, so in terms of microabrasion, what it actually means is removal of thin layer of enamel using your 18% hydrochloric acid or 37% phosphoric acid with pumice. Okay, what this does is actually changes the optical properties, but however, it's limited to the outer surface of the enamel and is more effective in the brown molting. Okay, but the drawback about microabrasion, it can cause sensitivity of the tooth. So in order to counteract to that, we advocate to use the use of tooth mousse after microabrasion. Okay, this is a picture of microabrasion. You might have to do it in a few cycle, and you may not get the result immediately, but over time that you will see that the tooth appearance is much better. Okay, combination technique. This is very good in a case of yellow-brown lesion. Okay, what you actually do is you use your 37% phosphoric acid and you apply for 60 seconds, and then you bleach the tooth with 5% sodium hypochlorite, then you re-etch, and then you apply some clear fissure sealant or bonding agent. Okay. Icon was mentioned much earlier, but then the use of icon for the anteriors is actually more for its aesthetic properties, because what it actually does is, as I said, that it infiltrates into the tubules. And the good thing about icon is it has the refractoral index of resin, which is very much similar to the healthy enamel. So it actually gives you a very good aesthetic outcome. All right. This is good to be used in cases of white spot lesion. However, you need to follow up this patient. It can lead to discoloration. Okay, this is the icon procedure. You can actually get this in the catalog. Okay, tooth bleaching. Some schools do not agree with the idea of tooth bleaching, but you can actually bleach the tooth if there is nothing else you can do and it's really of aesthetic concern to the patient. But you want to do a very slow bleaching rather than a very drastic bleaching. So basically what it does is actually camouflage the white opacity by increasing the overall brightness of the tooth. As you know, any sort of bleaching has got its drawbacks, as insensitivity, mucosal irritation, and enamel surface loss. Okay, what you actually do is you do daily bleaching with 10% carbamide peroxide on a custom fitted tray. But you might want to, the protocol that actually advocate for use of this bleach is you you have to alter this with your tooth mousse. So meaning to say, in a week, if you're using 3 days of hydrogen peroxide, that means Monday, Wednesday, and Friday of hydrogen peroxide. On the Tuesday and Thursday, you might want to use your tooth mousse. This is because you want to get your enamel remineralized well. Okay, so this is how it looks like. So direct composite restoration, this is quite straightforward. Yeah, you just remove whatever bit, but then again, you have to be careful for no pulper involvement. Yeah, okay, these colors and all these things. And as I mentioned just now, to improve the composite strength, bond strength, you might want to pre-treat the tooth by removing the protein with 5% sodium hypochlorite. Composite veneer, okay, you may not even have to remove any enamel surface. You just etch, bond, and place some composite for aesthetic purpose. You can use your opaque composite to actually mask the discoloration. Okay. Then when the child is much older, you might want to get the child to do something more aesthetically pleasing, such as porcelain veneers or crowns. Okay, so the take-home message today is identify the case, yeah, and do the preventive regimes and do the timely appropriate treatment. And bear in mind, this child doesn't just come and end in one visit. The child will require multiple visit with multiple disciplinary care and a long-term treatment. Yeah. So whatever you hear, we tend to forget. Whatever we see, we tend to remember. But whatever we do, we understand better. So with whatever knowledge that we have, what we have shared here, perhaps if we start treating and doing the necessary work for MIH teeth, we will know how it responds, and probably we can improve ourselves. This includes for myself as well. Okay, a little bit on advertisement for our upcoming MAPD 2021 Virtual Scientific Conference. Okay, I was looking into the list of speakers, and I must congratulate MAPD for actually, roping in all these renowned speakers. I think it's quite it's going to be a very good session. We have a lot of speakers from radiology department. In fact, the whole thing is actually about radiology. Yeah, so please sign up and please do join us. Okay, with that, thank you very much. Any questions, you can actually email me. Yeah. Thank you.
Okay, thank you very much, Dr. Bhavani. That was an insightful, very informative, and most comprehensive lecture I've ever heard. So thank you very much for all the for all the information you've shared with us. I'm so delighted because I think the most important thing is how to diagnose the condition. When we diagnose the condition, when we correctly, or especially the severe one, then we differentiate it between the caries, then we can come to a proper treatment plan. So Dr. Bhavani, actually we have about three questions. Two from Dr. Weni Villajas. She asked, can fluoride be used to treat MIH? And how often do you apply fluoride for the affected tooth? And the second question from her is, can silver diamine fluoride be considered for treatment for hypersensitivity? Over to you, Dr. Bhavani. Dr. Bhavani, can you switch on your speaker? Because we cannot hear you. Dr. Bhavani?
Yeah, sorry. Okay, I think I've already answered the questions in the presentation. The use of fluoride, yes. Fluoride is, as I mentioned, we want to incorporate fluoride, lots and lots of fluoride into the tooth substance, because we want to change the component of the enamel from hydroxyapatite to fluoroapatite, which is relatively stronger. And how frequent do you place fluoride? Well, our water is actually fluoridated. And we are actually, most of us are actually using a fluoride based toothpaste. So on a recall basis, if you're actually applying 3 to 4 monthly, I think it should be good enough. If you're putting in some you're putting in some Durafat or whatever not. Having said that, it all depends on the severity of the condition and also the compliance of the patient. to whatever regime that you're actually recommending. Because I have patients where you give them tooth mousse and they just don't use it, so it's kind of a waste actually. So if the patient is not very compliant, then maybe you want to cut them to come more frequent to your clinic for in-office use of fluoride. Yeah, and the use of SDF, yes, as I mentioned just now, yes, it is the upcoming trend, and SDF with GIC base is actually advocated for severely hypomineralized molars, especially those cases with sensitivity. Does that answer your question?
Okay, I hope that answers Dr. Weni questions. But if you have any further, Dr. Weni, if you have any further confusion and you want to ask Dr. Bhavani, we also will ask Dr. Bhavani and we'll give the answer in our Facebook page. The second question is from Dr. Yogeswari. She asks whether in your experience, Dr. Bhavani, does icon improve appearance of brown discoloration on affected MIH in incisors? Thank you.
Hi, Dr. Yogesh. Okay, we have been experimenting. Let me be very frank with you. We have been experimenting with icon, right? I personally noticed that icon alone doesn't really help so much in brown appearance, but what I would suggest to do is probably you need to do some micro abrasion first. Then you might want to bleach the yellow brown area, then do icon infiltration. There is actually a new there's actually a reported case on this combination technique, which perhaps I can share to you personally about the use of multiple techniques to actually tackle yellow brown appearance. Yeah. I hope that answers you, Dr. Yogesh.
I think that's answer her question. Okay, and then we have last but not least question from Dr. Shahida Idris. She asks, since MIH gives problem in etching and bonding, wouldn't it compromise the composite restorations over time?
Oh yes, it does. It does. That's the reason why you will have to. They actually advocate the use of 5% hydrochloric acid to pre-treat the tooth, so that you actually remove all the protein components and enhance the bonding. That's the reason why you actually have to etch it longer and etch it, in fact, twice, as I mentioned just now. Then again, as I said to you, all these MIH cases, you might want to come get them back on your recall list, and when you actually get them back, you actually have to check the integrity of the restoration. You might have to touch up the restorations, or perhaps change it to a better material as time goes on. In my practice, what I do is I place Fuji 2LC as a base. It's a GIC base, Fuji 2LC. Then I restore with Composite P60, which I find it really helps. Yeah, I have no affiliation to any particular material or any brand, but then again, yeah, this is what I use and I think it helps. Yeah.
Okay, thank you, Dr. Bhavani. Okay, actually, I have many questions, but because we have from myself, but because we time is so short, I just want to ask, because you share with us a few guidelines, right? But you said
Yeah.
the guidelines were not so. It means it's not very.
Yeah.
Yeah. So basically, but in your experience, which guideline do you can recommend for us to, at least for our reference, that you use for your, for your practice, that basically you based on for your practice, or can you just
Yeah.
share with
Sure.
us?
All this guideline has got its advantage and its disadvantage. So eventually what happens is you pick a bit of everything and you try things for yourself. With whatever your skills, your personal skills, and your local setting. Yeah. The latest guideline seems to be quite good. Yeah. You can actually get it in the website. It's quite comprehensive, and it actually tells you step by step what to do. Yeah.
Yeah, maybe it's good that we also, we also produce our Malaysian guideline, maybe lead by you.
We have guideline for every tooth? I don't think so.
No, for
We need a
MIH,
guideline.
I don't think we have guideline for in diagnosing and treating MIH, because this term is actually relative new. It's only
Mm,
emerged in the millennial, which is in 2001, right?
yeah,
So actually, it's basically the condition is, from your lecture, is already long existing, but the terminology has changed.
yeah,
Only the terminology is being confirmed
yeah,
in 2001.
yeah.
So with that, I have a very great time listening to your lecture and gaining knowledge from your lecture, Dr. Bhavani. Thank you very much. It's a
Thank
delightful
you.
lecture. So on
Thank
behalf
you,
of
Rosie.
MIPD, I would like to thank you, Dr. Bhavani, and also everyone that has supported our webinar series, an online event of Malaysian Association of Pediatric Dentistry. I would like to take this opportunity also to invite everyone to become MIPD member, and as Dr. Bhavani has shared in her few last slides, to join our event next year, which is in 2021, we have our scientific conference and also competition. So with that, I thank you everyone, and I end this lecture, this session, this webinar session. Thank you.
Thank you. See you all.
Bye.
Tastes like strawberries on a summer evening, and it sounds just like a song. I want more berries and that summer feeling. Someone